Hello, this is BIOC211, Lecture 19, Part 1, and we're looking at cardiovascular system disorders now. So in this session, we're looking at understanding how and why the symptoms and signs of cardiovascular disorders appear, and we're also looking at understanding the clinical examination for heart disease. So firstly, I would like you to go to your textbook and have a look at, this is the Porth textbook, have a look at chapter 29, it's on page 712, and you'll find a really excellent review on the information on the structure and function of the heart and the cardiovascular system. And I think that's going to get you in the right mindset for these future lectures. But I'm going to give you a really brief overview now. This image shows you the location of the heart within the chest cavity, and that black dashed line indicates the pericardial sac. So looking at the layers of the heart from outer to inner, you see the pericardium. This has a tough outer fibrous layer that covers the heart, and it also has an inner two-part serous layer, and the epicardium is the visceral component of that inner layer. The myocardium, this is the muscular portion of the heart, and the endocardium is a thin three-layered membrane that lines the heart. So the most important thing you need to remember is that the heart is a four-chambered pump. So the four chambers of the heart are the two atria and the two ventricles. And this image shows us the great vessels. So the main ones that you hear about a lot are the pulmonary arteries and veins, the superior and inferior vena cava, the descending aorta, and then you can see there the arch of the aorta. The valves that you can see labelled here, we're going to talk about them in the next slide, but the main thing to remember about valves is that they prevent the backflow of blood. So this image is a transverse plane. So if the heart was cut horizontally, this is looking down into that, into the bottom portion. So there are a few different types of valves. The semilunar valves. These are the pulmonary valve and the aortic valve. And then there's the atrioventricular valve. So they are between the atria and the ventricles. So the bicuspid valve, this is also known as the mitral valve, and that's on the left side of the heart. And then the tricuspid valve, which is on the right side of the heart. Here's an overview of that circulation of the blood. So if you start at 1 with the blood in the left ventricle, you can see that flow through the aortic valve into the aorta and the systemic arteries, etc. So the step-by-step is basically pulmonary circulation moves blood through the lungs and creates a link with the gas exchange function of the respiratory system. And then you've got systemic circulation, and this is what supplies blood to all of the other tissues in the body. And so that can be summarised by this image. You can see all the different steps in the correct order. Coronary circulation, so this is just looking at those coronary arteries that lie on the surface of the heart rather than internally. And then this diagram shows those main components of the intrinsic conduction system. So you're looking at the SA. This is the electrical system of the heart, keeps it pumping. So the SA node, the AV node, the AV bundle or bundle of His, as it's also known, the left and right branch bundle branches, and the Purkinje fibers. The cardiac cycle refers to that rhythmic pumping action of the heart. It's divided into two parts. So there's systole, and that's when the ventricles are contracting. Remember, the ventricles are down the bottom. And the diastole, and this is when the ventricles are relaxed and filling with blood. So let's move on to investigations into cardiac function. So non-invasive investigations are electrocardiography, also known as ECG. So this is done for a number of reasons. The exercise stress ECG, it's an exercise ECG, but it's also called a stress test. A lot of people say they did a stress test or an ECG that was done on a treadmill. So these are they're detecting ischemia, and yeah, they are done on a treadmill with an ECG hooked up to see what happens to the heart under that stress. The ambulatory ECG, this is a Holter monitor, and this is a portable digital recorder, and it basically records between 1 to 7 days of the heart function. So it's looking at arrhythmias, palpitations, dizziness, syncope, so when people pass out or faint, Also, this information that's done from these ambulatory ECGs is transmitted to the hospital via phone or via the internet. Echocardiography, this is often used as well. This is also known as an echo, and this is a Doppler device. And there's, if we just skip down to that bottom, that's a better explanation of this. So the Doppler studies, they amplify and record sounds that are made by blood flowing through the peripheral vessels. So with that echo, it is a type of Doppler device. So it looks for the speed and the turbulence of the blood in the chambers and also the great vessels. So the greater the frequency, the faster the blood's flowing. And that can also be used to detect valvular regurgitation and turbulence, and also high blood pressure. There's also X-rays, ultrasonic examination. So this is looking at the chambers of the heart and the valves. MRI can also be used for a number of different purposes, but very good for looking at structural functions. Now here's an image. I'm not sure if you've seen this before, if you did it in previous courses, but this is what an ECG result looks like when they're reading it, to see if those peaks and troughs are exactly as they should be. So just a few reminders. The P is referring to the depolarization of the SA node, and that's at the beginning of atrial systole. The PR segment, so that's this little bit here. This is full atrial systole. So this lasts about 0.1 of a second. The QRS interval, which you can see down the bottom, in the middle, this is the end of atrial systole, and this is when that pressure builds in the ventricles with all of the 4 valves closed. The ST segment, so this is ventricular contraction, so that's about 0.3 of a second. And then that end T to the P point, that is ventricular diastole, and that's when the atrias fill. Okay. So other different tests of cardiac function. So these are a bit more invasive methods of assessment. Nuclear imaging with radio-labelled chemicals. We've talked about nuclear imaging in a number of the other lectures that we've already done. This looks for hot spot, cold spot imaging. Cardiac catheterization. This is performed under a local anaesthetic and within a sterile environment. This is when a catheter is introduced percutaneously. So this means that's a term to explain when they access an internal organ via the skin through a needle. So they use that method and into the vasculature, and it's passed into the atrium and the ventricle. They can do a right heart study where they look at brachial and femoral veins, and they can also do a left heart study where they look at femoral artery, when the femoral artery is used. And they do this first in the atria and then in the ventricles. They use a catheter to measure the chamber pressures, to take blood samples for assessing oxygen content, and they can also inject contrast to visualise the chamber function and also the valve function. And sometimes they can also take biopsies of tissues using that method. Coronary angiography. So there is a bit more information on the next slide. I'll go into that. So this is where a catheter is inserted into either the left or the right femoral artery, and then that catheter enters the common iliac artery and goes into the aorta, goes all the way up. And then once that catheter slides around the arch of the aorta, so it goes all the way up, it goes all the way up, and then it comes around that arch of the aorta, and then can be directed into the coronary artery. And this is where they can inject dye, and then they can take x-rays, and they can observe the extent to which the artery is blocked. So this can lead to an appropriate judgment of what the next course of action is. So they could either do some of the options would be a balloon expansion of the vessel if it's constricted, and also arterial stent insertion is done sometimes as well. Here is an image of an angiography. So in that first one on the left, you can see where that yellow arrow is pointing to. This is a severe stenosis of the middle right coronary artery. So see how skinny that is? And then if you look at B, this is an intracoronary administration of nitroglycerine. and that results in that complete resolution of the stenosis because of the vasodilation and also vasodilation of that entire right coronary artery. So you can see that's very significant improvement in perfusion following the treatment. So all of those blood vessels are getting that full flow of blood to the area. Now, when we're looking at clinical examination of cardiovascular system disease, these are some of the main things that we're looking for. So breathlessness, this is very common, body weight and BMI changes, pulse rates, so they're looking at the rate, the rhythm, the volume. Obviously, that's very, very strongly linked with the cardiovascular system. Blood pressure, of course, face, mouth, eyes and hand pallor. Cyanosis, so is there ballooning, like very obvious signs that there's no blood flow to the area. Finger clubbing is also a sign of cardiovascular disease. Listening for those heart sounds is important. You can hear murmurs, you can hear various changes, and you will learn that in clinical examination. In the abdomen, looking for ascites, remember that's that fluid accumulation in the peritoneal space. Hepatomegaly, that's enlargement of the liver. And you can see looking for changes in those peripheral pulses in the legs and also swelling in the legs. Peripheral edema it can be right heart failure. Pulmonary edema you see in left side heart failure. And also when we're talking about ascites in the abdomen, portal hypertension due to can happen due to right heart failure, and either by itself or with pre-existing left heart failure. All right, so chest pain, this is a very obvious sign of cardiovascular disease, or although we've mentioned it can be a sign of other things such as reflux, etc. But the characteristic is really important. So what's the onset like? Is it radiating? Is it local? Is it provoked by anything? What are the characteristics of those pain? Often people describe cardiovascular pain as crushing, stabbing, even spasmodic pain. There's other cardiac causes of this chest pain, so myocardial infarction, angina pectoris, pericarditis, this dissecting aortic aneurysm, and mitral valve prolapse. And in mitral valve prolapse, you can also see lower ventricular ejection and therefore lower coronary flow that can lead to that chest pain. Other causes, lung diseases, psychogenic. So often people who have a very strong strong family history of cardiovascular disease may be really fearful of having myocardial infarction, and so they may suspect chest pain as a cardiovascular symptom, even when it may not be the case. Esophageal disease we've mentioned, musculoskeletal. So muscle spasm and intercostal muscle spasm can also be causes of chest pain. Breathlessness or dyspnea, it's the same thing. This is unpleasant subjective awareness of the sensation of breathing, and we've mentioned this before. So there are a number of cardiac causes as listed here. Also respiratory causes need to be ruled out. So asthma is obviously a cause of breathlessness, and that can come on suddenly. Remember, we've talked about allergic reactions, so type 1 allergy hypersensitivity reactions can result in asthma. So people may think they're having a cardiovascular issue when it's actually a type 1 hypersensitivity reaction. However, it's always important to rule out cardiovascular causes, of course. Chronic obstructive pulmonary disease and other bronchial issues. Other forms or reasons for dyspnea, orthopnea, paroxysmal nocturnal dyspnea is also another one to consider. Hypertension. We most likely all know someone who has hypertension. It's very common. Systolic blood pressure does rise with age, and also the incidence of cardiovascular disease is closely related to blood pressure. So we're going to talk more about hypertension very shortly in a future presentation or lecture, but here's just a little look at what's going on when blood pressure is being measured, and I'm sure you've all had your blood pressure measured, And if you haven't done it already, you will do this in clinical examination courses. All right, here are some of the other presentations. So syncope, this is when someone faints. So that's a sudden loss of consciousness. Pre-syncope, so this is when people have that lightheadedness. They may feel a bit spacey or see stars. There are, of course, cardiac causes of this is listed here: arrhythmia, ventricular dysfunction, aortic stenosis. But also neurogenic causes need to be ruled out. So epilepsy, transient ischemic attack, and also through the autonomic nervous system. Things like when someone might see blood or something that shocks them, they can obviously faint. Metabolic causes, hypoglycemia is a common one, and inappropriate vasodilation. So postural hypotension. So when someone's sitting down or laying down and they stand up very quickly and their blood pressure is low from lying, it doesn't increase fast enough to get the blood flow all the way up to their head, then they can have an issue with syncope. Palpitation. So this is that abnormal subjective awareness of the heartbeat. This can be caused by abnormal rhythms. So as we mentioned earlier, paroxysmal tachycardia, ectopic beats, atrial fibrillation, forceful heartbeats, also things like anxiety, anemia, excitement, too much caffeine. These can all cause heart palpitations. Patients often describe palpitations in a wide range of sensations, so it's not the same for everyone. It's really important to establish symptoms, so you need to quiz patients on exactly what they're feeling. So they need to be asked about associated signs and symptoms that may be present. So things like shortness of breath, are they having or do they experience anxiety with that heart palpitation? That's a very common one. People will say that they feel tightness in their chest and their heart's racing, and that is a very common symptom of anxiety. But it also, as I've mentioned before, cardiovascular presentations do need to be ruled out, especially if they're presenting with other signs and symptoms of cardiovascular issue. Lightheadedness can also needs to be asked of these people. Are they having lightheadedness? What's happening with their alcohol consumption? Are they smoking? Or have they just exercised? Or does it happen when they've had a very high level exercise, etc.? Okay. Cardiac arrest and sudden cardiac death. So myocardial ischemia, acute myocardial infarction, prior myocardial infarction with scarring can all be causes of this. Structurally, aortic stenosis, hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmic right ventricular dysplasia, and congenital heart disease. These can all be structural causes of sudden cardiac death. Things that aren't related to structural disease, long QT syndrome, also known as Brugada syndrome. This is a genetic disorder, and this can be characterized by defective sodium channel function and also abnormal ECG results with a right bundle branch block. There's also Wolff-Parkinson-White syndrome. This is when there's abnormal fibers of those Purkinje, and they connect to which connect the atria to the ventricles, and they conduct in a retrograde direction, so they're going the wrong way. Adverse drug reactions are also a possibility here. Also, severe electrolyte imbalances can cause sudden cardiac death. All right, so abnormal heart sounds and murmurs. This may be the first clinical manifestation of heart disease before any of those other signs and symptoms that we've mentioned. Clinical evaluation, of course, is helpful. Echocardiogram is often needed to confirm this. It's important to think, okay, does the heart sound normal? Listening for pleural rub or venous hum are two of the things that are important to differentiate. This is pericardial friction that produces a scratching or a crunching noise. There's also pathological murmurs, and so these are usually due to what's known as turbulence, rapid ventricular filling, and abnormal valve function. There's also systolic murmurs, and these can be due to anemia, and also pulmonary stenosis can be a cause of that. All right, so we whizzed through those, and I'll see you shortly for some disease states. See you soon.